Thank you very much for the introduction, and thank you for the organisers for this fantastic symposium. And I should own up from the very beginning, because this looks like a very clinical title for my talk. I am not a clinician at all. I'm actually a population geneticist. But I happen to be working at a hospital and work with many clinical collaborators that you'll see a little later on in the talk. And we've got some sort of new, unpublished, exciting discoveries that I'm going to talk about today. So what I'd like to cover in the talk is a sort of a narrative that gets us to, and I'm going to give you the punchline straight away, a large effect allele that we found in a biobank in New York, and then how we could move this forward through the translation pipeline and even into the clinical implementation pipeline. But before I do that, I'm going to start and talk a little bit about ways we think about relationships and relatedness. I'm going to tell you a little bit about the biobank in New York. It's called the BioMe Biobank Program, and it's at the Icahn Institute of Medicine at Mount Sinai. And then I'm going to tell you about some methods we've developed and how they've allowed us to actually pinpoint large effect recessive alleles in that population, or at least one today. And then working with clinical colleagues, how we move that into the clinical healthcare setting. Okay, so I thought it might be just very useful and instructive to start out in a very informal way, thinking about how we think about relatedness. And we can do this in many constructs, and they're all rather useful. We think about relationships in terms of pedigrees and kindreds, and sometimes in terms of genealogy. If you're a PopGen person like me, you can think about it as in terms of the coalescent. But really, it's very similar ideas that relate how we are all related and ways in which we are all related. A sort of way that we've already heard about in this conference from Philippe's talk yesterday that we can think about it is through how we related along our genome through tracts of genome that we share identical by descent. So I'm sure I don't have to explain this to this room, but just to refresh us. This is a very simple concept. If we are directly related, in this scenario, we have half siblings. We will share tracts of our genome transmitted from both parents, and at some portion of the genome, we will share homology across those tracts. So here, in this scenario, these half-sibs share this red portion of their genome in this common shared boundary, identical by descent. And these figures are from a really nice review on this by Brian and Sharon Browning that came out a couple of years ago. So there's some nice properties of identity by descent, or IBD, that can be useful to think about for many applications. And we're going to zip through some of them. This is not really going to be a quantitative talk, but I thought it was nice sort of to annotate this on the slide. So we can think about relationships at a little bit more distantly. And in this scenario, we have fifth cousins to each other who may still share tracts of the genome identical by descent. However, our tract sharing decays very rapidly, and it decays according to this exponential equation. However, if we share IBD, the tract length of the IBD decays rather linearly, and according to this equation, and there's an expected tract length exponential distribution around this, is sort of an average chromosome length divided by number of meiosis. Is really straightforward. So this leads us to some sort of intuition about what we might expect to observe in terms of IBD sharing. So for example, if you are full fifth cousins, as we showed on the previous slide, on average you would expect to share pointwise IBD about 0.05% of your genome. However, in practice, most fifth cousins don't share IBD at all. However, if you do share IBD, so if you are both genealogical and genetic relatives, you would expect to observe a tract length about 8 centimorgans. And you can go through this exercise, you can go further out. If you go out to 20 meioses between any two pairs of individuals, your chance of sharing IBD becomes very, very small. But even 20 meioses out, if you share a length of IBD homologous by descent, you would expect that length to be quite appreciable, so something like 5 centimorgans. So we can think about this because the chance for any pair of individuals of sharing IBD diminishes as we get separated by meioses, but of course we have many, many ancestors. So at an individual level or even at a population level, IBD sharing can actually be quite abundant. And of course, IBD sharing is shaped by demographic forces. In particular, it's shaped by recent demographic forces, such as bottlenecks, such as cultural practices of endogamy, mixture, migration, and others. Okay, so we already learned yesterday about how you can take this sharing of IBD and you can use it to reconstruct some demography features of a population. We learned about the lovely genetic structure along the river in Quebec. But another application which I'm going to focus on today is how we can use this observed IBD sharing at a population level and sort of borrow ideas from linkage analyses for methods called IBD mapping, or other people think about it as a population-based linkage. And I'm going to go through an example of how we have applied this. But it is, not only my group, but many other groups are applying these methods predominantly where there's most IBD sharing observed in the population, and these are usually founder populations, to some success for discovering disease loci. Before I dive into telling you about how we've applied this method, I want to step back a little bit and tell you about the populations in which we are applying this method. And to do that, I'm going to talk about the BioMe Biobank. Okay, so the BioMe Biobank, as I mentioned, is in the Icahn School of Medicine in New York. The Icahn School of Medicine is part of a continuum network of medical centers, and we've got many centers around Manhattan and also in Queens and in Brooklyn, 7 main medical campuses, but then very many other clinics around the city. Here's what Mount Sinai looks at. It's often quite easy to miss in the campus, like a campus institution. You can walk straight by and not realize there is a medical school there. It's what I call a vertical campus. It's actually a rather ugly building. It's sort of a bit of an eyesore on the side of Central Park in the Upper East Side, bordering Upper East Side and East Harlem. But the views from inside are very nice. And in the center, as I mentioned, we have an ongoing biobank program that has been ongoing since way before I arrived, since 2007, and it is led, chief architect and director of the Institute by Dr. Erwin Bottinger. And I'm not going to go into too much details because this room is very familiar with biobank efforts, except for a few facts. We're at about 32,000 individuals currently enrolled. We roll at a recruitment rate of about 500 individuals per month, or participants per month. We collect just blood plasma, and we extract just DNA. We're not a tissue biobank. Importantly, and I think this is by virtue that we're one of the more recent biobanks, we wrote into our informed consent an opt-in structure, and that we may recontact patients, and this becomes very important later on when you make genetic discoveries. You might want to recall individuals not just by phenotype but also by genotype. So I mentioned that we are located in Upper Manhattan. And it's very useful to think about our location in terms of the neighborhoods that are served by the medical center. So this is some nice data from the Weldon Cooper Center, and simply takes census data from the US and then plots each individual as a point overlaid onto the map of Manhattan. And in this map, you see that people are categorized by US census categories that ask about race and ethnicity, self-reported race and ethnicity. So blue for white, green for black, red for Asian, and orange for Hispanic. And you can see that although Manhattan Island is very diverse in its populations, these populations tend to segregate to particular neighborhoods. And if you're familiar with Manhattan, I'll point out this is the Upper East Side, this is East Harlem, which is mainly Hispanic, and this is Central Harlem, which is predominantly African and African American. Okay, so our population in the biobank represents the neighborhoods that we serve. So we have a highly multi-ethnic biobank, and you can think about it in proportions of self-reported ancestry. So our biggest population are Hispanic Latinos, about 35%, and about 30% self-reported European ancestry, about 25% African ancestry, and about 10% either other ancestry, mixed ancestry, or people who don't self-report as any of those categories. Okay, I'm going to be the third person this conference to use the iceberg analogy, because of course this is only the tip of the iceberg, and census categories can be useful for some applications, but really oversimplify the diversity and populations and cultures that live in these neighborhoods. So one of the things that we do when we enroll patients to the biobank is we ask them about their ancestry, particularly where they were born, where their parents were born, and where their grandparents were born. So if you take a map of the world and you plot in terms of regions where people themselves were born, straight away you see that there's a big diaspora community in these neighborhoods. And in our biobank, about 35% of participants were not born in the US, and really they come from all around the world. If you go back 2 generations and ask, well, where were your grandparents were born, you see there's some slightly different patterns, and a whopping 65% of people had grandparents born outside the US, coming from all over the world. In particular, this would be early 20th century, because the median age of the biobank is about 60 years old. So grandparents coming from about the early 20th century from Eastern Europe and Southern Europe mainly, and if you know the history of migration to the US, that this makes sense. But a large proportion of our participants actually come from the Caribbean. That is the largest region of the world that's represented in the biobank. And actually, our Hispanic Latino community in the biobank is itself very heterogeneous and diverse. So people sometimes think of East Harlem as being predominantly Afro-Caribbean or predominantly Puerto Rican, but actually there's every country almost in the Americas is represented in this community. And we can see this in genetic space. So we know this because people tell us when they enroll, but we can also see this rather easily in genetic space because Hispanic Latino populations have ancestry from 2 or 3 different continents, and you can see this on this PCA plot. You can see African ancestry, European ancestry, and Native American ancestry as reference populations, and Hispanic Latino populations, which are represented here in many colors, really falling between these 3 groups, continental groups. So Afro-Caribbean populations predominantly on this climb between European and African populations, with a little nudge up here toward Native American populations. So there is some small Native American ancestry usually within individuals from this group. But of course, ancestry is very variable along this climb. So if you are Puerto Rican, you can belong anywhere in this space. And then other populations from North and Central Americas falling rather on this climb between European and Native American reference panels. So these are populations from Ecuador and Mexico. So despite this large heterogeneity and enormous genetic diversity, we see persistent patterns of relatedness in these populations. So here we're looking at identity by descent, and on the x-axis here, we're summing the lengths of the IBD tracks that are shared between every 2 individuals, and on this axis here, we're counting them. So you see, by chance, and we don't collect families, but these are densely populated neighborhoods that are close to the medical center. By chance, we discover people who we can see quite clearly in genetic space are very directly related, so people who are siblings or grandparents and grandkids. And you can see this very easily in genetic space too, that they share large amounts of their genome. But the rather interesting thing from the point of view of thinking about how you can leverage IBD is that we see this persistent pattern of people who are rather more distantly or cryptically related. And in this scenario, you have people who share actually small proportions of their genome in 1, and you can see the sort of edge effect, 1, 2, 3, 4, and maybe 5 segments along the genome. But in summing it together, it's actually a small proportion of the genome. But the track lengths are not that short, so we can be quite confident that given the number of observed genotypes, that this is homologous by descent. Okay, this is another way of viewing that IBD, and this is taking a bird's eye view on these populations. So in this plot, every point is an individual, and a line drawn between each node is a relationship. So I've drawn in here all those second-degree relative relationships that we learned from the IBD before, and you can see that there is second-degree relatives predominantly within the Hispanic Latino, but also within the African and African-American communities, not so much actually in the self-reported European. I didn't mention it, but we can tell genetically that about 40% of our self-reported European are Ashkenazi. Now, if I plot on that more distant relationships, people who share a track greater than 3 centimorgans, identical by homologous, so identical by descent by inference, you see that this actually pulls out some of the patterns of sharing and demography within and across these populations. So something that's rather useful to consider is, on a population average, what is the average sharing between within populations, and we know Ashkenazi Jewish populations, which is a canonical founder population and practices of endogamy, that there's on average something like 3% IBD sharing. This is congruent with other published reports, somewhere between 2 and 8%. We observe something close to 3% in Manhattan. But outside of Ashkenazi Jewish population, the next most sharing population are the Hispanic Latinos, about 0.25% genome on a pairwise average shared, which is obviously an order of magnitude lower than you find in Ashkenazi populations, but quite a deal higher than we observe in other non-founder populations. And we can kind of get a little fancy with this. We can go in at the subcontinental level to try and understand if there's a specific structure in specific regions across the America. And when we do this, we find out that most of this sharing is actually being driven by populations coming from the Dominican Republic and Puerto Rico. In fact, there's almost as much sharing in these populations when you consider them together as we observe in Ashkenazi populations. And not so much, for example, sharing in Mexico and other populations. Okay, so now I'm going to talk to you about how we can use this for gene discovery. And we actually, when we were applying these methods in Hispanic Latino populations, we wanted to pick a trait to sort of play around with. And we thought that height was a particularly interesting trait to start to think about in terms of developing these methods. Mainly because height, as was mentioned yesterday, is sort of a poster boy polygenic trait, that there's large, 250,000 person GWAS analyses in this, for this trait. So we actually know a lot about the genetics of height in European populations mainly. But also because height is really, I think, kind of endlessly fascinating, and it's rather structured. So as we see in Europe, we see a decline of differences in population means in height across the Americas. It's not quite the north to south that we see in Europe, but it's patterned nevertheless. So there's about 4-inch difference between populations in some populations in the Afro-Caribbean region compared to shorter populations from Mexico and Ecuador. But the other reason that we were particularly drawn to this trait is because there was many outliers for extreme height across a lot of these populations. So there's some outliers for very tall stature, but most of these outliers are in the clinical short stature range, which I'm told is something less than 4'11". Sorry, I know I should be converting to metric, but it's tough. It's on the slide though. So we proceeded with our population-based linkage, and I'm not going to go into exactly how we do this because most of this is published, and of course there's many groups working on these methods these days. Some of these methods a lot more elegant than the ones that we're using now, but I will point out the people who worked on developing these methods. This is Sasha Gusev, who's now up in Alkes Price Labs, and this was in the lab of my graduate school advisor. It's a pair. So Sasha developed these two methods, and this method was actually developed at 23andMe. It's a really nice method for catching errors and switch errors. In absence of perfectly phased data, detecting IBD can actually be nuanced and tricky. But the point is that once you detect IBD, you can cluster it as people who share IBD in clusters of 3 or more. And then once you cluster the IBD together, you can encode it as you would encode an allele, and then you can associate it using your favorite method, much like you would perform a GWAS. So long story short, we did a GWAS for height. We came up with a number of regions of the genome that surpassed our empirical permutation threshold, but I'm going to just tell you about this one here, which we immediately got excited about. And this is sort of a zoom in on this region of the genome. It's on chromosome 9, and just to kind of give you the analogous SNP association, this is what the SNP association looks like, and as you can see, it's rather flat and uniform. There's no signals that are really peaking up here. Whereas when you associate these haplotype clusters, you get a whole cluster of haplotypes that are significantly associated with height, as indicated in red. If you pull out one of these haplotypes and just lay out the actual IBD tracks themselves, you can see it here. You can see this common shared boundary. The whole region is about 10 centimorgan region, so think of linkage peaks, not GWAS. But if you pull out the common shared boundary of the topmost haplotype, it falls somewhere here. But really, probably this whole region is implicated because all of these haplotypes are in rather LD. Now, our first thought when we ran this analysis was that, well, perhaps what we've really done using IBD is pull out a big pedigree. I've told you that there are related individuals in our population. It turns out that's not the case. If you actually look along the whole genome for members of this cluster, you find some people are directly related. So we have a couple of people in there who are related. But the vast majority of people, there's about 50 or so people in this cluster, are not related off the context of this haplotype. So they don't share relatedness in the rest of their genome. And the reason we were very interested in this haplotype straight away is because straight away we saw that if you have 2 copies of this haplotype, you have a 7 to 10 inch reduction in stature compared to the population mean. So that's 20 to 30 centimeters, I think. I might have that wrong. So we had 4 individuals that we discovered in our discovery effort who were significantly short-statured. So on average for women, 4'2". And we had one male who was, I think, 4'11". And just as a point of interest, although I'm not going to talk too much about this, when we actually layered on top of that the local tracks of ancestry coming from Europe, Native American populations, and Africa on the background of these haplotypes, we found as well that we are significantly enriched for what you see as blue on this plot, which is actually the Native American component, far more than we see along the rest of the genome for these individuals. So this is a very, very strong enrichment, and I'll point out that these people along the rest of their genome look rather more European than African or Native American. Okay, so we found something that seems to have a very strong effect on height, and I'm next going to talk about how we can interpret that and translate that, and then even use that to improve healthcare for people who are affected with this. And I'm going to point out that all of this work was really driven by the fact that I'm, not a clinician, but I'm sitting next to clinicians. So this is Nora Abul Hussein, who's a medical geneticist who actually sits in the office next to mine. And as Gil said yesterday in the panel, it really takes a multidisciplinary team to be able to not just discover, but really interpret the clinical meaning of these variants that we discover. So the other advantage of IBD mapping, perhaps over GWAS, and certainly when you're using data that's not a direct observation of all sequence variants, such as sequence data, although the associated regions may be rather large compared to GWAS, it does actually point you to the exact individuals and the exact region of the genome that you should be looking to find the variant. And the other expectation is that you only expect to find one causal variant in this region because these tracks are rather recent. So we straight away sequenced the 4 individuals who were homozygous, and again, long story short, we very, very quickly found that what we believed to be the candidate underlying causal variant, which was this missense mutation in a collagen gene called collagen 27A1 that resided in the region. Now, we could go to the literature. So there are collagen genes that are already implicated in short stature syndromes and orthopedic syndromes. This was certainly not a previously known collagen gene, but if you go to PubMed, you can find out that there is some functional work done on this gene. In particular, there's a knockout in mice, and you have this nice dwarf mouse, and there's a zebrafish morpholino, where you have this sort of scoliosis effect, as they call it in the paper. And we know something about where this gene is expressed. It's expressed in the growth plate of bones, and it's responsible for the turnover of cartilage to bone during bone development, or thought to play a role in that at least. So this was a very interesting candidate with some, at least from the literature, functional indication that this might be playing a role in bone development and hence a role in short stature. But this is where it actually really gets interesting, because of course this is a biobank, so we have the electronic health records of these affected individuals. So we can actually go to the electronic health records and try to fill out what is the actual phenotype driven by this variant. And this is sort of a model in which we can use variants, sort of, thinking of a sort of bridging model from ways in which we've always thought about monogenic disorders and rare variant diseases, that we can do this for variants and disorders that are a little bit more common. And then actually, because we have these large effect alleles, go directly into translation and using linked data in the EMR. So we went into the EMR, and it straight away appeared to us there's something more syndromic going on. So the 3 people that I have here on this chart, in terms of the resolution of their records and what appeared in them from their medical record, it certainly appeared that at least 2 people had congenital hip dysplasia. It's actually not that common, certainly not in older age. And osteoporosis and a particular sort of cervical stenosis as well. Again, not that common, so certainly an enrichment, even though we've only got n equals 3. And then if you also go into surgical record, you can see that 2 of our 3 people had large joint replacements at an early age in life, so in their 40s, knee and hip replacements. So it certainly seemed that this is some evidence that this could be syndromic. And we got very lucky, because at the same time that we discovered this and we were learning this in the electronic health record, another group using exome sequencing in families in Puerto Rico identified the exact same mutation as the causal variant underlying something called Steele syndrome, which is actually really well phenotypically described syndrome. And the features of the syndrome, which are outlined here, are rather similar to what we're observing in our patients in the health record. So as well as short stature, we're looking at scoliosis, and we're looking at joint pain and joint problems. Some of these features we don't see in the electronic record due to the resolution of the data, and we're actually seeing some things that weren't seen in the previous families that were studied for this. And in particular, we also see some things that cause for concern. There was one patient who had been diagnosed and in fact was taking medication for rheumatoid arthritis that we actually think is probably not that. It's probably actually pain in the joints due to Steele syndrome. Certainly there's no indication in the record whatsoever for any of these 3 individuals that they ever had a diagnosis of Steele syndrome. Okay, so following on for this, what we can do, because I explained we have Recontact built into BioMe Biobank, is reach out to these affected individuals in the biobank, invite them to come back in, and them and their families for sort of a translational perspective study of a deeper clinical phenotyping and radiologic measures for Steele syndrome, so we can describe it. We're particularly interested in describing it in older individuals. A lot of what we know is actually in children. But even more than that, we can, as you know, hand in hand with sort of describing this in greater detail, we can start to think about screening for it. And so we can do this in a number of ways. We actually have a genetic testing laboratory that develops tests in Mount Sinai. And we have been working with them to develop a clinical screen, so a clinical genotype actually and sequencing panel for this variant in collagen 27A1. I just got a text this morning before I came on stage that they've just completed and validated that test, so it's now up and running and can be ordered at Mount Sinai. And we can actually, and this is, when I say we, it's actually largely Nora, can actually, using methods that Rex described yesterday that really come from a lot of development in the eMERGE network, build clinical screening algorithms to go in and identify in our patient database of about 4 million patients who might have this syndrome based on discriminatory features of this syndrome. And as a demonstration project, what we're planning to do is partner with providers who are most likely to see people with this syndrome. So these are a number of collaborators, Robert Rappaport, Abigail Allen, and Molly Riegelman, and the Pediatric Endocrinology and Orthopedic Service at Mount Sinai that we were planning to work with so that when patients present as suspected Steele syndrome affected, we can both screen them, so we can order the test. They can go for genetic counseling and have the test ordered, and we can learn about what might be proper healthcare management guidelines for these individuals and develop a management structure. And the long-term idea, sort of combining these approaches, would be to roll this out in a system-wide way with a sort of clinical decision support alert that says we think that the patient you are seeing based on clinical features may have Steele syndrome and that this test is available. Okay, and then the other thing that we are certainly thinking about is really understanding, so we discovered this in a sort of heterogeneous Hispanic Latino population. We happen to know because we've asked people where they are from, but that's not often the case. It's certainly not the case when people walk into the physician's office. So we really want to get a better understanding of what communities are at risk for this. So far we have screened a panel of short stature Hispanic Latinos from all over the Americas. And these are individuals who are either below 4'11" or in the 90th percentile for height in their populations. And so far, we've only observed this in Puerto Rican communities. We've actually rolled this out now to a much larger screen, and I think, sort of hot off the presses, I think that we might see it in other communities. Now, I told you that this is actually on the Native American component, so from the population genetics perspective, that makes a little sense if this is really coming in the Taino component. But certainly within Puerto Rico, this particular allele seems to account for something like 10% of all short-statured people in Puerto Rico, and which means it has a carrier frequency of about 5 to 6%. So this is actually not a very rare disorder. This is actually not an uncommon disorder at all. Okay, so I'm going to finish up there with just a few thoughts. So I sort of went through a roller coaster narrative of how we can go from sort of thinking about PopGen and demography to actually applying those theories and using them to discover variants that, at least in the case of Steele syndrome, probably have a significant public health risk. We heard a lot in this meeting about how many rare variants are out there, but I think the point of this exercise is to show that sometimes there are some rare variants that are going to be common somewhere. And if the trend for the rest of the genome is followed, some of those rare variants will have large functional effects. So, this certainly advocates that we should be considering breadth. We should be sampling all populations. But as we scale up to mega-scale genomes, we're actually going to have a much easier time and be able to discover much more fine-grained detail about all these demographic events, some of which we'll be tracking with disease variants. Okay, and that's it. Thanks very much.
Thank you. One or two questions.
Great talk. It was very exciting. So I have a question on the nature of the mutations that would allow to use IBD and the same methods. So here you have a recessive disorder with a mutation that has a fitness, it seems like a fitness of 1. There's no impact. So if we're talking about more common phenomenons where there might be a little impact on the fitness, would this still work, or you really need an allele that has no negative pressure applied on it, or?
Right. So, so we don't actually know about the fitness of this allele. So we have too few observations to make too many statements yet about the fitness of this allele. You know, I think, so, and I think we had this discussion yesterday. I think if something's really deleterious and really has a, you know, a functional effect that's really, really harmful, of course, you're not going to see this arise to appreciable frequency in any population. But there's, I think, not many, but very important alleles out there that have a large functional effect that may have some effect on fitness, but certainly not enough to overcome, you know, genetic drift or other demographic forces that allow that to arise to appreciable frequency and probably affect the landscape of functional variation in human populations and probably disease. So this is one of them. But I suspect there may not be too many, but there are probably others out there, and certainly, you know, decades of linkage research and research in founder populations supports that.
I have a quick question for you. As you integrate this into the medical care, who pays for the testing?
So actually, the really fun and exciting text I got this morning is Mount Sinai is going to cover the cost of the test. So certainly for their research effort and the prospective studies. With regard to people coming into the clinic, that would be billed to insurance. So it would be go through a genetic counselor or genetic medicine and be billed to insurance.
So it's been approved that will be paid for through the insurance?
I beg your pardon?
So you have clearance from the insurance company that they will pay for?
No, not yet. So this is certainly early days, so we haven't gone that far. That's a very interesting point.
Thank you very much.
Thank you.
Thank you.